Welcome back to the Deep Dive. Today we're looking at something that feels, well, almost fundamentally broken in how we diagnose disease. I mean, think about it. For more than 100 years, the gold standard, histopathology, it's all based on a bit of a simplification, isn't it?
It really is. Human tissue, your body, it's all 3D, obviously.
Right, a tumor isn't flat. It has depth, complexity, different bits doing different things.
And exactly, heterogeneity.
But the diagnosis, often the critical one, comes from looking at what? A single, super thin 2D slice on a glass slide.
Yeah.
And that's not just, inconvenient. It creates this huge issue called sampling bias. It feels like trying to understand a whole city just by looking at one photo of one street corner.
Yeah.
Maybe you miss the important part entirely.
Especially with cancers like prostate cancer, which are known for being really variable internally. That one slice, it might look okay, but miss the really aggressive focus just, a millimeter deeper.
So that's where we're jumping in today, this inadequacy of 2D.
Precisely. And we're exploring a potential solution called TriPath. It's a deep learning platform, AI basically, but it's designed to sidestep that 2D limitation entirely.
Okay.
TriPath doesn't care about individual slices so much. Its whole goal is to analyze the entire 3D tissue volume.
A whole block.
The whole block. And our sources suggest the potential here is massive. By looking at everything, the full picture, TriPath seems to perform much better than the traditional 2D methods. And it's not just about being faster or fancier. The real aim is better, more stable risk prediction for patients, getting it right more often.
Okay, let's unpack this sampling bias thing a bit more.
Yeah.
I get the concept, but pathologists are trained to target the worst-looking area, right?
Yeah.
So how can looking at the whole thing automatically be that much better than a really targeted slice? Doesn't that just add noise?
That's a great question. And it comes down to just how incredibly complex tissue heterogeneity can be. Targeting often isn't enough. The sources point out that even a targeted 2D slice captures, just a tiny, tiny fraction of all the shapes and structures in there. We kind of know this already, right? Pathologists often get better results if they look at multiple levels cut from the same block. That tells you something.
Okay, so more slices help.
Yeah, but it's more than just missing a bad spot. A lot of the important microscopic structures, things like how glands are branching in 3D or the actual shape of cell clusters, they can look really ambiguous, or you might not even see their true form in just one flat cross-section. You lose the architecture.
Like seeing a slice of intricate plumbing, you don't know where the pipes actually go.
Exactly.
Yeah.
That 3D structure is critical for accurate grading, for understanding how bad it really is. You need the whole picture, not just one snapshot.
So if 2D slices aren't enough, we need tech that captures the whole volume. That means moving beyond standard slides. What did the study use?
Right. They used two main non-destructive 3D imaging methods. First up was something called open-top light sheet microscopy, OTLS.
OTLS. Okay.
Think it like a super high-res 3D fluorescence imaging. They use special clearing techniques and fluorescent stains, sort of like a fluorescent version of the usual H&E stain pathologists use. And the resolution is amazing, 1 micrometer per voxel. That's way finer detail than the standard 5 micrometer thick slice you get clinically.
Wow, okay. And the second one?
The second was microcomputed tomography, or microCT. This is more like a super detailed 3D X-ray.
Like a CT scan, but tiny.
Pretty much, yeah. Lower resolution than OTLS, about 4 micrometers per voxel, and it's single channel, so more like black and white compared to OTLS's color. But crucially, it's also non-destructive and gives you that full 3D reconstruction of the tissue block. Both methods essentially create a digital twin of the whole sample.
Okay, so we solve the not enough data problem of 2D, but we run straight into a too much data problem.
Precisely. These aren't just images, they're gigavoxel data sets. Billions of data points per sample. Yeah. A human pathologist just can't sit there and scroll through billions of voxels. It's completely impractical, time-consuming, probably error-prone, too.
Right. The challenge flips entirely. It goes from trying to infer 3D from limited 2D to being overwhelmed by the complete 3D picture.
Exactly. And that's where the AI TriPath comes in.
Okay, perfect timing for a quick recap. We've established that standard 2D pathology struggles with the 3D reality of tissue, leading to sampling bias. New 3D imaging tech like OTLS and microCT can capture the whole volume, which is great, but creates these absolutely massive gigavoxel data sets that humans can't realistically analyze manually. So that leads to the listener question. If the data is too big for people, How on earth does TriPath manage to predict something complex like patient risk using, you said, millions of tiny patches without any pathologist pointing out where the cancer even is?
Yeah, it sounds almost like magic, but it's down to a really clever AI approach. The core idea is weakly supervised learning. You might also hear it called multiple instance learning, or MIL.
Weekly supervise. Okay. Less
Yeah.
input needed.
Way less. Think of it like this. TriPath doesn't need someone to painstakingly draw circles around every single cancer cell or grade every single patch. That would be impossible with this much data. Instead, it only needs the overall patient outcome, the big label.
Like what?
So for the prostate cancer work they describe, the only label TriPath got for each entire 3D sample was, did this patient have biochemical recurrence, meaning did the cancer come back within 5 years? Just a simple yes or no for the whole patient case.
Wait, hang on. So you feed it this massive 3D scan and just tell it, this patient's cancer came back or this one's didn't, and that's it.
That's pretty much it for the core supervision. It's remarkably minimal.
And how does it figure out what in that giant 3D image is related to the cancer coming back? It has to learn somehow.
It does, and it does it through a smart pipeline. There are basically 3 main steps. First, tessellation.
Tessellation, like tiling.
Exactly like tiling. It takes the huge gigavoxel input volume and sort of mathematically chops it up into thousands and thousands of smaller, manageable 3D cubes or patches. They call these instances.
Okay, so break the big problem into lots of small pieces. Makes sense.
Step 2 is feature encoding. Each one of those little 3D instances gets fed into a powerful, pre-trained deep learning model, like a 3D convolutional neural network, CNN, or maybe a 3D vision transformer. The job of this encoder is to compress all the visual information in that patch down into a compact set of numbers, a feature vector. It's a massive compression, like reducing the data per patch by maybe 1,000 times or more.
So turning pictures into representative numbers. Got
Yeah.
it. Makes the data crunching feasible.
Right. And then the third step, and this is really the clever part, is aggregation.
Bringing it all back together.
Exactly. You've got thousands of these feature vectors, one for each patch. The system needs to combine them all to make that single final prediction for the whole volume. Did the cancer recur? Yes or no? And it uses something called an attention-based aggregation module.
Attention. Like, it pays attention to certain patches more than others.
Precisely. The attention mechanism automatically learns to assign an importance weight or attention score to each patch. Patches that contain features strongly indicative of recurrence get a high weight. Irrelevant or benign patches get a low weight. So it figures out which parts of the tissue are prognostically important on its own without needing any prior labels pointing them out. It's learning to find the needle in the haystack.
Okay, that attention mechanism is the key then. It lets the AI focus on the critical spots within that huge volume, guided only by the final patient outcome. That's pretty smart.
It is. And they validated this idea first using simulated data, like digital phantom tissues, where they knew the ground truth.
And what did the simulation show? Does the 3D part really matter?
Oh, absolutely. The results were stark. When
Yeah.
they analyzed the whole simulated volume using 3D features, TriPath's main approach, the prediction accuracy measured by AUC was incredibly high, like 0.974, almost perfect.
Okay.
But then, if they analyzed the same volume but only allowed the AI to use 2D features, sort of like stacking individual slices, the AUC dropped quite a bit, down to 0.803.
Still decent, but a big drop.
A significant drop. And then if they simulated standard pathology just looking at a single 2D plane through the volume, the AUC plummeted to 0.677, barely better than chance.
Wow. Okay, that's convincing. That really highlights that the 3D structure itself contains unique information that you just lose in 2D.
Exactly. It's not just about seeing more tissue, it's about seeing the shape and architecture in 3D. That seems vital.
Right, that makes sense.
Yeah.
So the simulations prove the concept. Now, the crucial part, how did TriPath do on real patient data?
Yeah.
Predicting actual biochemical recurrence, BCR, that's the outcome that really matters.
This is where it gets really interesting, as you say. They tested it on 2 real clinical cohorts using those imaging methods we talked about. First, the high-resolution OTLS cohort.
Okay, the high-def version.
Yep. And TriPath, using the whole volume in 3D, achieved an AUC of 0.860 for predicting BCR.
0.860. How does that compare?
Well, it was significantly better, statistically speaking, than the baseline of just analyzing representative 2D planes from the same volume, which got an AUC of 0.816.
So, a clear win for 3D again.
A clear win. And the authors argued this boost comes from 2 things. 1, obviously analyzing vastly more tissue, but 2, capturing those genuinely 3D features you just can't perceive in 2D slices. But here's the really striking comparison. the standard clinical benchmark. After surgery, pathologists examine the entire removed prostate to assign a Gleason grade. That's the gold standard for risk assessment post-op.
Right. The definitive grade.
TriPath 3D, analyzing only the initial tiny biopsy tour, achieved an AUC of 0.860. The post-operative Gleason grade from the whole prostate, its AUC was 0.761.
Whoa. So the AI, looking at just the pre-surgery biopsy in 3D, was significantly better at predicting recurrence than the final grade given after looking at the entire removed prostate.
That's what the data showed. A nearly 10-point AUC improvement using much less tissue taken earlier. It's pretty remarkable.
That is remarkable. Okay, but comparing to a single grade is one thing.
Yeah.
How did it stack up against actual pathologists looking at the biopsy images?
Yeah.
They did a reader study, right?
They did. They got 6 specialist GU pathologists to look at H&E style images derived from the 3D OTLS scans.
Head-to-head. AI versus humans.
Pretty much. And the result, TriPath 3D outperformed every single one of the 6 individual pathologists. It also outperformed their consensus score when they looked at the standard 3 slices.
Wow, right.
And it also, again, beat the standard post-operative Gleason grade baseline.
But they took it a step further, didn't they? Something about giving the pathologist more data.
Yes, this was fascinating. They thought, okay, maybe pathologists are limited by only seeing a few slices. What if we show them everything? So they gave the pathologist access to the entire stack of 2D images from the OTLS scan. We're talking over 300 image levels per biopsy. That's like 100 times more visual data than they'd normally see from a biopsy.
Okay, now it's a fair fight, giving them all the 2D info.
You'd think so. But even with access to all that slice data, the pathologist's consensus performance only improved to an AUC of 0.799.
0.799. But TriPath 3D was.
0.860. Still significantly better.
I'm genuinely stunned by that. Giving expert pathologists literally 100 times more image data, the full stack, and they still couldn't match the AI analyzing the volume in 3D.
It really suggests something profound, doesn't it? It implies that the human brain, even a highly trained one, finds it incredibly difficult, maybe just non-trivial, to mentally reconstruct and interpret that full 3D complexity from hundreds of stacked 2D images. The AI seems to handle that volumetric information more effectively.
That's a huge point. It's not just about seeing more, it's about processing it in true 3D.
Exactly. And this wasn't just a fluke with the fancy high-res OTLS data. They repeated the analysis on the other cohort, the one using the lower resolution single-channel microCT imaging.
Right, the less detailed 3D scans.
Even there, the same pattern held. TriPath Whole Volume 3D achieved an AUC of 0.749, which again significantly beat its 2D baselines and the clinical Gleason grade baseline for that cohort, which was AUC 0.712.
So the benefit of 3D analysis holds up even with different imaging tech and lower resolution. It seems pretty robust.
Very robust. The core advantage of analyzing the whole volume in 3D seems consistent across modalities.
Okay, another checkpoint. TriPath 3D is consistently beating 2D analysis. It's beating expert human pathologists, even when they have access to all the slice data, and it's doing this across different 3D imaging types. Impressive stuff. So the next question is, how is it doing this? You mentioned the attention mechanism finds important areas, but how does analyzing the whole volume specifically address that sampling bias problem we started with, and what is the AI actually seeing in 3D?
Right, let's tackle the sampling bias first. They did specific tests called ablation analyses. Basically, they started with a small part of the 3D volume and gradually increased the amount of the volume fed into TriPath. And the prediction accuracy, the AUC, consistently went up as more of the volume was included. That directly shows that analyzing more tissue closer to the whole thing improves performance by capturing more of that crucial heterogeneity. It dampens the effect of getting unlucky with one small sample.
Okay, more data helps reduce the risk of missing something.
Exactly. And they also did what they called a plane variability analysis. This is really insightful. They looked at how the risk prediction would change if you based it on just a single 2D slice, but varied which slice you chose from the 3D stack.
Simulating the standard process.
Precisely. And what they found was for heterogeneous tumors, the risk prediction could swing wildly depending on the depth of the slice you happen to look at. You could literally have a case where one slice predicts low risk and another slice just a bit deeper predicts high risk.
Wow, so the current standard practice is potentially like diagnostic roulette depending on which slice ends up on the slide.
That's a good way to put it. TriPath, by looking at the whole volume and aggregating the information with that attention mechanism, averages out that variability. It gives a much more stable, consistent risk prediction that's less dependent on the luck of the draw of a single slice.
That makes perfect sense. It stabilizes the prediction by considering everything. Okay, so it mitigates bias. But interpretability is key for AI in medicine. We need to trust it's not just a black box. How did they figure out what features TriPath was learning?
Yeah, absolutely crucial. They use a technique called integrated gradients, or IG. You can think of IG as a way to ask the AI, okay, you made this prediction. Which parts of the input image were most responsible?
So it highlights the important bits.
Exactly. It assigns an attribution score to every single one of those small 3D patches we talked about earlier. A high positive score means that patch strongly pushed the prediction towards unfavorable prognosis or recurrence likely. A negative score means the patch indicated a more favorable outcome.
And when they looked at the patches the AI highlighted as bad news, what did they see?
This is where it really clicks. The patches with high positive IG scores, the ones TriPath flagged as most indicative of recurrence, consistently showed morphology that pathologists already know is bad. Things like infiltrative carcinoma, glands that looked poorly formed or fused together, what pathologists call Gleason pattern 4, and complex, messy structures like cribriform architecture, all known markers of aggressive prostate cancer.
Okay, that's reassuring. It's not finding some weird, uninterpretable signal. It's identifying known high-risk features.
Precisely. And conversely, the patches with strongly negative scores, the ones indicating good prognosis, tended to show large, well-formed, benign glands, sometimes with these little calcifications called corpora amylacia, again, features associated with benign or less aggressive tissue.
So the AI essentially learned to recognize established prognostic biomarkers on its own, just from the weak supervision of patient outcomes.
Yes, but with a crucial difference. It learned to recognize them within their 3D context and quantify their extent and severity across the entire volume, something that's incredibly hard for humans to do consistently from 2D slices. It confirms the AI is learning clinically relevant information.
And it's leveraging the 3D information to do it more effectively.
That seems to be the key. And one final piece of evidence for robustness was cross-modal generalization.
Meaning?
They trained a TriPath model only on the lower-res black and white microCT data. Then they tested it on the high-res color OTLS data after converting it to look similar, and it still worked well.
And vice versa.
And vice versa. Trained on OTLS, tested on microCT. It suggests TriPath isn't just memorizing artifacts of one specific scanner type. It's learning the underlying 3D morphological signatures of cancer aggressiveness that are consistent regardless of how you image them.
That's really powerful. It points towards a truly generalizable understanding of the 3D structure of the disease.
It does. It really strengthens the case.
Okay, let's try and sum this up. What we're seeing with TriPath is pretty groundbreaking. It's using AI, specifically this attention-based, weakly supervised learning, to tackle the massive data sets from 3D imaging. It overcomes the limitations of traditional 2D pathology, that critical sampling bias, by analyzing the entire tissue volume. And crucially, it outperforms not just 2D methods, but also expert human pathologists, even when they have way more data than usual, likely because it can process that complex 3D information more effectively.
That's a great summary.
And it's interpretable. It learns to identify known high-risk 3D features, confirming its clinical relevance, and this ability seems to generalize across different imaging types.
Absolutely. And thinking about where this could go clinically is maybe the most exciting part.
Right, the so what factor.
Because these 3D imaging methods, OTLS and microCT, are non-destructive. They don't require slicing up the tissue block like standard pathology.
So the original tissue block remains intact.
Yeah. Exactly. Right now, if you want to do detailed molecular tests on a biopsy, you often have to cut more slices, potentially using up valuable tissue, especially if the biopsy is small. Imagine a future workflow. You get a biopsy, you scan it in 3D with something like microCT or OTLS. TriPath analyzes the volume non-destructively to give a really accurate risk assessment, like a 3D pathology consult. And then the entire original tissue block is still perfectly preserved. You can still do any follow-up molecular tests needed or archive it safely. You haven't destroyed the evidence, so to speak.
That's a huge practical advantage, especially for things like prostate cancer, where decisions about active surveillance versus treatment are so critical and often rely on integrating pathology with molecular data. Keeping the tissue intact is a big deal.
It really is. This non-destructive aspect, combined with the superior accuracy, could pave the way for new laboratory-developed tests, LDTs, based on computational 3D pathology. It offers a path to getting more information more accurately without consuming the sample.
So this research definitely seems to push computational 3D pathology much closer to clinical reality. It addresses the why and the how.
It really lays out a strong case.
Which leaves us with a final thought, really, a question for you listening. TriPath showed it can better identify and quantify known 3D features linked to prognosis. But what about the unknown? What completely new 3D morphological biomarkers, complex shapes, architectures, spatial relationships that are just invisible or incomprehensible in 2D might AI frameworks like this discover in the future?
Yeah, that's the next frontier.
Not just for prostate cancer, but for other complex diseases too, like pancreatic cancer, maybe brain tumors. What hidden structural clues are waiting in the third dimension?
The sources strongly suggest that while this first wave is about confirming known biology in 3D, the next wave will likely be about discovering entirely new structural insights, moving biomarker discovery from the 2D slice to the full 3D volume. AI like TriPath might be the key to unlocking that.
A fascinating glimpse into the future of diagnostics. Thanks so much for walking us through TriPath today.
My pleasure. Really interesting stuff.